Good afternoon, everyone. Thank you so much for spending your Wednesday afternoon with us. This is the TennCare team. My name is Victor Wu. I'm the Chief Medical Officer, and I'm joined by other members of our team who I'll introduce when they speak on their section in the webinar. Today's webinar is around the TennCare Medication-Assisted Treatment Network and having a chance to share with you some program updates as we continue to work on treating members with opioid use disorder and opioid dependence here across our TennCare program. In terms of a few logistics, please make sure to have your line muted. We will record this webinar as well as provide the slides after our presentation to the TennCare Opioid Strategy website. We will try to have them posted within 48 hours, so if you have any questions or need the slides for reference or would like to watch it again, feel free to go to the TennCare Opioid Strategy website and retrieve the slides at that point. In terms of questions, we welcome any questions that you might have. We will be taking them through the chat function. Feel free to enter in questions at any point throughout the presentation, and we'll answer any at the end that we have time for. Please make sure to identify your name, your organization, as well when you're asking your questions. Today's agenda really is to kind of give an update and an overview of where we are as we continue to work on our addiction recovery treatment services network here in Tennessee, specifically around the medication-assisted treatment therapy network. Additionally, we want to provide some concrete and helpful and actionable information around the formulary changes for contracted MAT providers, which allow for contracted MAT providers in the TennCare MAT network to prescribe Bunavail as well as buprenorphine naloxone generic, as well as give a tutorial and brief update on the prior authorization process, which we've tried to streamline and increase the ease of use for providers in the contracted network. Lastly, we want to spend some time hearing from our MCO partners who have taken a tremendous amount of leadership in helping to build the MAT network in terms of tips and tricks for billing and coding. And lastly, we have a few other final policy updates from the TennCare side that we hope that you find useful. As a review, we've been working on the TennCare opioid epidemic for many years, but within the last year and a half, under the leadership both of our TennCare leadership and also under Governor Haslam, as he has put together a comprehensive package, we really focus on how TennCare can continue to identify opportunities to support and combat the impact of the opioid epidemic that we've seen here in Tennessee over the last several years. We have across the board been having a comprehensive strategy focused on primary prevention, secondary prevention, and tertiary prevention, as many of you have heard. We shared a similar version of this slide in May at our webinar at that time, and wanted to give you just a short update on some of the progress we've made and to continue to show areas where we see such important leadership that you all as providers treating patients with opioid dependence are going to play in helping us stem some of the harmful health outcomes that we've seen now for the several years from the opioid epidemic. The first one, as you all remember, is in January 16 of this past year, we implemented new opioid TennCare benefit limits around the prescription of opioids for first-time and non-chronic opioid users. So those individuals who have never used opioids before, or were not using them chronically, and were just taking them for a short acute indication, a lot of the medical evidence suggested that there was overexposure as well as overprescribing occurring, not just in Tennessee but nationwide, to those individuals. As a result, we placed a benefit limit trying to help support best practice prescribing patterns, as the literature was starting to show, around first-time and non-chronic users. And you'll see here a graph that represents the amount of opioids that we have now seen in terms of acute and chronic users in Tennessee. I'll draw your attention to the far right of the graph, the two bars there, and really since the implementation of our TennCare opioid benefit limits, which began in early January, we've seen a tremendous decrease in the number of first-time and non-chronic users or acute users of opioids in the TennCare population through the TennCare paid pharmacy benefit. The largest drop we've seen, even though we've been working on this for several years, has occurred between the last 2 quarters of last year and the first 2 quarters of this year once we put in the TennCare opioid benefit limits. Additionally, we recognize that chronic opioid users who may already be using opioids long-term may have some dependence or underlying chronic use of it. We wanted to make sure that those individuals had a more safe and coordinated care pathway to making sure they access healthcare services such as alternative pain treatment, alternative pain medications, and or accessing recovery and treatment services that may be useful for them as well. And so what I'd like to highlight there is our policies, again, have not had a major impact on the chronic users, and that was by design. And overall, one of the major focuses, as evidenced by today and all the work that you all do, is to help support our chronic users and those that may be struggling with opioid use disorder to access high-quality treatment, including MA treatment, to really help them move to a safer and active recovery process. Second, we wanted to look at the impact of the opioid benefit limits on the way that prescriptions are occurring for first-time opioid naive and acute users. What you'll see here is, again, two graphs before and after opioid limits were put in place. On the left-hand side, you'll note that while the majority of our prescriptions for first-time users or acute opioid use was less than 6 days, we still had a significant percentage, almost a third, that were written for their first prescription 7 or more days. Some of them were even greater than 15 days. Since the implementation of the opioid benefit limit, as well as through a lot of the public campaign, provider education, the TN Together legislation, we've seen a tremendous shift in the prescribing patterns of our TennCare providers for first-time and non-chronic users, in that they are providing now much more short courses and fewer MMEs for their members for first-time or acute opioid use. We hope that together these efforts will continue to impact and to help decrease the amount of overexposure for members who may be using opioids for the first time. However, we still understand that even though primary prevention will be a necessary step to help reduce the overall pipeline of members who may become dependent to prescription or illegal opioid substances, we still see that there's a tremendous need for the treatment network to really help surround and support members who are struggling with opioid addiction or opioid dependence. We've shared this with you all before, but wanted to review our near-term and long-term timeline for the way that we view building out the TennCare MAT treatment network here for our program, of which all of you played a very important role. As you know, we began with establishing MAT program description and quality standards that would allow for a evidence-based best practice set of guidelines to really support those of you who are providing high-quality care to members through MAT. Once we accomplished that, we wanted to begin to build the access through our MCOs. Our MCOs have taken a tremendous leadership role in reaching out to MAT providers, mental health specialists across the continuum of care, whether it's from outpatient therapy, the primary care, all the way up to intensive outpatient or inpatient rehabilitation, trying to connect the recovery treatment network so that a member who enters in at any point in those processes who needs help may be able to find and seek help from a addiction treatment specialist, and to connect those treatment specialists back to their primary care provider. The third major step that we've been focusing on now is really increasing coordination of care and clinical integration, meaning we want to make sure that our members have access to the types of care coordination services that will help them maximize their chances of recovery success, working with the providers to make sure that the providers who are offering these resources have the ability to connect across the continuum, and really support our members' journey, which we understand may oftentimes involve a relapse along the way, and making sure that we can catch those members in the safety net and catapult them back into the treatment network to really help them maximize their chance of recovery. And over the long term, we hope to begin to identify good outcomes, best practices, and really begin to use value-based payment incentives to help support outcome-based interventions that really are leading to members maximizing their chance of recovery. We're really excited to be along this journey with you all, and we really appreciate all the support that each of you all have played in this role or are considering playing. We think it's necessary that we engage with multiple providers, multiple MAT providers, mental health specialists, clinical care coordinators, and our MCOs have partnered with us to take the lead on this. I've been using the phrase contracted MAT provider a few different times, so I wanted to make sure that I level set for everyone on the call. There is a distinction between those of you in our TennCare network broadly providing MAT, and specifically today who we are talking about, which is a contracted MAT provider. As you know, from our webinar in May, we've been having an increased effort to identify MAT providers such as yourselves that are practicing evidence-based guidelines, including and supporting clinical care coordination, behavioral health, co-occurring counseling, those types of best practices that we're learning from the literature. And so the contracted MAT provider really represents a MAT buprenorphine contracted provider who has a Medicaid ID, who has reviewed and provided all services outlined in the program description that we've shared, attest to the MAT program description for each MCO they contract with, complete contracting or attestation with each of the individual MCOs they choose. We recognize that each MCO may have a different term for their network. It may be the buprenorphine MAT network or BMAT. It may be the contracted MAT network. It may be the TennCare MAT network. But regardless, the important thing is that today, as we speak about the additional opportunities and benefits around the formulary and around the PA process, when we refer to the contracted MAT provider, we're talking about those providers who have completed the process or in the process of completing the contracting, specifically around the buprenorphine program description. We shared with you in May the program description, and it's the same one that's being used by all three of our MCOs. A lot of the information here was developed and taken from best practices across multiple national bodies such as ASAN and SAMHSA. Again, today's focus will continue to be on buprenorphine, primarily because we understand there are different federal regulations governing the prescription of buprenorphine. However, we completely and wholeheartedly support the role that naltrexone has as a medication-assisted therapy option, and there is a separate program description that exists for naltrexone. Many of these same principles cross over to the naltrexone provider community. However, today is really focused on buprenorphine, again, given all the different regulations that are placed on by the FDA and by the DEA around buprenorphine. As we mentioned in May, I wanted to highlight again that there are many benefits to contracting as an MAT provider. There's not only clinical care and coordination support from the MCOs, helping your members get connected to behavioral health specialists or primary care, helping with transportation services, all the types of additional details that have to be completed and thought of in order to help maximize a person's chance of success. We've also broadened the TennCare MAT formula for the contracted MAT providers, which you'll hear about today, which includes the generic buprenorphine naloxone sublingual tablet. We were looking to identify ways to increase data transparency so that you can understand what is happening to your patient's journey once they leave your office, including primary care visits or visits to the ER or to the inpatient side. We want to increase the data transparency so that you can begin to identify what works and what doesn't work for your members. And lastly, each of our MCOs has taken a tremendous leadership role in identifying opportunities for increased reimbursement to make sure that the best practices are being implemented for their members. It is another benefit to contracting as a dedicated contracted MAT network provider. I'll move on to the formulary section now. I'll introduce Dr. Renee Williams-Clark. Dr. Williams-Clark is our Chief Pharmacy Officer, and she's going to walk us through the next two sections around the formulary changes as well as the prior authorization process for contracted MAT providers.
Thank you, Victor. As he mentioned, my name is Renee Williams-Clark, and I'm the Chief Pharmacy Officer here at the Pharmacy Unit for TennCare. And I'm thrilled to be partnering with the providers' health plans, as I find this is a wonderful opportunity to accept provider feedback and make actionable programmatic change. So we'll settle in over the next few slides as they are related to the TennCare Pharmacy Unit agenda items, and that includes contrasting the formulary access and prior authorization operations for contracted MAT providers versus all other providers in the network. So in the next slide, we'll go ahead and take a look, and we've compiled here a list of key links associated with our formulary, including the TennCare Magellan primary pharmacy benefits webpage. We do have a single formulary that's available to all members, and these are the links that you would use to get there. Feel free to copy and paste or follow these or go to these websites as we're walking through the formulary process and the change. And or the prior authorization fax form, because they have been posted. Okay. And real quick, as mentioned earlier, the contracting prior to or contracting of MAT providers has allowed TennCare to broaden the formulary toolbox, as is highlighted in this slide. We really want to let you know that as a result, these contracted providers will now have access to an additional preferred agent, generic buprenorphine and naloxone sublingual tablet, alongside Bunavail. For those of you that are unfamiliar with our PDL and formulary layout, it's important to note the general information located on page 1 at the top of this slide. In particular, there are superscripts that are denoting just how utilization is handled. So PA is shorthand for prior authorization, and QL is shorthand for quantity limits. And as it denotes, the superscript denoted next to the drug name indicates the necessary utilization mechanisms that TennCare uses to manage its formulary. Or another way to put that is that formulary status is denoted by those superscripts. In addition to that, I would like to note that on the left-hand side of the page are the preferred agents on the formulary, and on the right-hand side of the page are non-preferred agents. And so for the MAT providers, we've actually provided subheadings just so you know and your staff knows that these agents are available to you on preferred status. The main point of emphasis on this slide is to assess or to provide the information about the additional preferred agent of generic buprenorphine naloxone sublingual tablet for these providers and the subheadings. So we'll move on to the next slide. And just like with the PDL, the corresponding criteria page is noted here. There's a subheading referring to those MAT providers that are contracted with the MCOs. And if you look on the left-hand side of the page, they're highlighted in red. You'll note the name of the drug, and immediately following that, or on the side, is its formulary status, preferred, non-preferred, and so on. In between, I do want to highlight the criteria on this page for the MAT providers. This has been pared down significantly, and on the next slide, you'll see the difference, but here, the primary thing you need to see is that all that's really needed to obtain access is a diagnosis of opioid addiction. And then, in addition to that, and just to get you more familiar with this criteria page, to the right hand of the actual criteria line items, you'll see quantity limits as well as a hyperlink to the prior authorization fax form. In the next slide, you'll see the difference I was referring to. At the top of the page, you've got the subheading for the MAT providers, again, those remaining non-preferred agents. And then right below that, towards the middle, you'll see all other TennCare providers and their access and the criteria, which is significantly longer. So we go to the next slide. And wrapping up that previous slide, just wanted to denote the differences between the subheadings and the offerings for those two different types of contracted providers. And then really quickly inform the group that there is an override that providers may be familiar with, but if you're newer to TennCare, you may not be familiar with our monthly script limits. There is a monthly script limit of 5 for all members, and there's a special titration dose override that's available at the pharmacy point-of-sale counter. Pharmacists are very familiar with this titration dose override, and they use it for other agents outside of this class, but within this class, if the pharmacist submits to us billing codes to clarify that this is for a buprenorphine titration, then we will only count that prescription once, up to 5 times. So essentially, a member could get the prescription for buprenorphine filled up to 5 times in a month, 5 separate fills within a month, and it only counts once towards their script limit. And so that's what this slide represents. If you actually run up against this edit or the script limit rejection code, or a pharmacist calls and advises you of the script limit rejection code, you should refer them back to either their monthly provider notice for the titration override, or have them call into the TennCare Magellan pharmacy website, and they will walk them through how to submit those codes. So that was the formulary changes. I hope you all are excited about it as we are. We've really had we put in a lot of work and thought and took some feedback from providers as we were working through this. But next, I really wanted to jump into our newly streamlined PA process as it relates to the MAT providers. So as we highlight that, I'm just going to give you a high-level overview of the differences between an MAT provider and a non-MAT provider and what they will encounter in the prior authorization process. So on the left-hand side, you'll see if you are, and follow this decision tree, if you are an MAT provider, you will complete 1 and essentially 1.5 pages of information and submit it for consideration. And it's up to about 5 questions. Really and truly, we've pared this down, and you can get it done in 3, so long as you're doing it within TennCare's guidelines. and requirements for coverage for preferred agents. Other providers would have up to 4 pages to complete and 14 questions. And so I'll go ahead and go to the next slide now. And really quickly, if you're following along or if you want to see this new PA fax form, we're pretty proud of it over here. You can click the link to the form or copy and paste the link to the form and go out and follow us along. But don't worry, if you're not willing to do that, we've highlighted it in the next few slides. So this is the PA fax form that we're all excited about. And ultimately, we want to really emphasize in the slide that this can be completed through Cover My Meds. So you have the option to complete this through electronic prior auth or EPA. You submit the completed form and the information, and it is routed then to Magellan. You don't have to do anything else. They'll get you a response back within 24 hours. Likewise, you can always fax your PA fax forms if that's your preferred method, or call it in. The other thing that's new about this section is that for the provider, there is a space to enter your XDEA number, but other than that, it really does look the same. It's the patient information and ID number and provider information and ID number. The next slide. Here on page 2, this is where we get into the meat of it. Are you contracted with an MCO in one of our MAT programs? Is that the TennCare MAT, the BMAT program? You just select yes or no here, and then you can actually move on. If you select yes and you are an MAT provider, then at that point you would select your product and your dosage. Next is page 2, and at the top of the page are those simple 3 questions where we're asking you, are you sure you're sure, and are you attesting to being a MAT provider or MAT network provider as defined by TennCare? You would select yes, you would provide the diagnosis, another check mark, and question number 3 is this a patient that, did you request prior auth for this patient in the past? Or is there someone else in your office that's requesting it, or is this patient new to you? And as long as you're within those TennCare guidelines and parameters, using a preferred agent and using within our benefit limit, you're done, right? So that's it. You submit it either through EPA, fax, or phone. That's up to you. But if you're going outside of those quantity limits, or you're exceeding if you're exceeding our benefit limits, or if you're choosing a non-preferred agent, then you would go on to the highlighted section that's highlighted in yellow and complete that portion. And then finally, we would get your signature and send it on. So just really quickly highlighting this right here, if you are within TennCare guidelines, then you will complete questions 1 through 3, sign it, and send it off. If not, you're going to complete 4 and 5 along with 1 and 2, and then provide documentation as to why you would exceed TennCare guidelines. Okay, next slide. If you are a non-MAT provider, then you do have a different pathway. It is essentially the very same PA fax form that we had prior to this program. You would provide product selection, see the sole preferred Univel agent listed there. You will then go on to the next page, and then you would have all of the other required sections and details. I think it's just important here to note that that's the Medicaid ID, the XDEA number, checking of the Controlled Substance Monitoring Database, and emphasis here is that if you have previously registered with the network and are an MAT contracted provider, you have already provided these types of details and attested that you are providing care in this manner prior to. But otherwise, we have no way to capture that unless we ask you in a PA fax form. So it's important to distinguish the two, and then let you know that this mechanism that we've used to streamline it, I hope, is very helpful to you all. So next slide. Again, Now we go on to the counseling visits and are requesting above the quantity limit and providing the documentation and prescriber signature. This all should look very familiar to you because this was the process prior to this new MAT network. Next slide. Couple of things to consider as you're submitting prior authorization through the pharmacy benefit, and that is there is an exception for splitting a dose and max daily limits. We do have edits in our system set up to only accept once daily dosing for buprenorphine, but we do recognize there are some cases when a patient is actively withdrawing that may require twice daily dosing, and if you will supply that information on the front end, it will greatly reduce your time and questions that come up on the back end. So if you have a situation like that, let us know on the front end and submit that with the original PA fax form. The other exception would be a buprenorphine mono product. Most of you have encountered a woman, unfortunately, who may be pregnant and requiring buprenorphine mono. That is an exception. And within TennCare guidelines, as well as if a member is transitioning to Bunevel and needs induction dosing for the mono product or transitioning off of methadone in that case. And then the final case would be a severe allergy to naloxone, or another exception might be is when we've discovered on our end under review that a patient has had either short course therapy of opiates or a prescription for opiates. That might be a reason for denial. But many of you may not understand or recognize that TennCare does have a single one-off exception criteria in which if there's a short non-reoccurring dose of opiates for pain due to surgery or procedure, that is considered an exception. So just wanted to emphasize here that these scenarios must be clearly outlined and explained on the prior auth form. Otherwise, they will track back and ask you if you have documentation. If you don't respond, the request would be denied. So next slide. Really quickly on the submission of prior auth and contact information, as you can see here, your electronic PA submission can be completed by using Cover My Meds. Again, the outcome is 24 hours. You can also complete it via fax. The fax the form to 866-434-5523, as well as just to call the Magellan Health Services call center. Phone number and fax are both included at the bottom of this slide.
Great. Thank you, Dr. Williams-Clark. With that, we'll turn it over to Mary Shelton, who's the Director of our Behavioral Health Operations.
Okay, you can go to the next slide. So first, a brief overview of the phases of the MAT treatment. So in order for TennCare and the MCOs to build a network of quality providers, we first developed the program description that Dr. Wu mentioned earlier in the webinar. The program description incorporates the 3 phases of MAT treatment seen here. The phases of treatment are induction, stabilization, and maintenance. We took these phases and then added minimum requirements for the treatment, aligning with the guidance from SAMHSA and the Department of Mental Health and Substance Abuse Services. Each provider will then use their own clinical judgment to determine how and when the member moves through these phases. You will also see in the upcoming slides that the MCOs have designed their contracting based on these phases. With us today are representatives from each of our contracted MCOs, Amerigroup, Blue Care, and United Healthcare. They will each provide a brief summary and an update on their contracting processes for the MAT providers. So up first, we're going to have Philip Morrison from Amerigroup. And Philip, are you on?
Yes, I'm here.
All right, take it away.
Okay, good afternoon, everybody. I am Philip Morrison. I am the Provider Relations statewide manager for both provider relations and contracting for all behavioral health services. And I'm going to take just a couple minutes to go over some billing tips for our MAT program, and also if you're currently not contracted with us for MAT, the best way to get in touch with us in order to start the process. Next slide, please. First, we're going to go into some billing tips. We have decided at Amerigroup to go ahead with a fee-for-service type model. As you can see here on the slide, we have got 2 codes that we're using for the medication visits. The first one is going to be the H2010 U1 and H2010. What the U1 is going to stand for, again, that's going to be the initial visit. That is going to be just your new patient visit, and then all other visits after that will be just billed with the H2010. So just an example for the induction phase, again, the first visit would have the U1, and then the other 3 visits within the month, or ever how many are medically necessary, would just follow up with the 2010. Again, there is no prior authorization required for this code, and it is also just for the medication services for the MAT treatment. Any additional services that are associated with the treatment, such as counseling, labs, peer support, any additional services like that are billed separately utilizing the appropriate HCPCS coding. So again, I just want to stress that our codes they're not set up in a bundled rate, and again, everything is based off of a fee-for-service type model. Again, for naltrexone, we will be utilizing just the standard E&M codes, the 99201 through 205 for the initial visit, and then also the 99211 through 99215 for any subsequent visits associated with that. And again, no prior authorization is required for those services. Next slide, please. Then we'll move into the stabilization and maintenance phase. Here again, we're utilizing the same codes. In this situation, the H2010 will be the only code that will apply. And again, that will be for any medication visit services that are rendered. Same with the naltrexone. All other services, again, will just be utilizing the standard E&M codes. Next slide, please. Again, as far as, did we skip one? Yeah, I think we skipped, back one. Thank you. Oops, the slide with the provider portal, please. I'm sorry. Here we go. Again, this is just our provider portal. It's got our address to the portal. Again, in the bottom right-hand side of the screen, there is an option to join our network. If you would, just go ahead and click on that and put in your information, and then one of our network managers will be back in touch with you. Also, our portal is used to check claim status, to file appeals. It's just going to be a wealth of service for each and every one that's part of our network. Next slide, please. These are our provider contacts and how you can get in touch with us. The first is our internal provider relations team. Again, all of our reps are typically out in the field 2 to 3 days a week, so the easiest way to get in touch with us is through the internal provider relations. It is a line that you can leave a voicemail, and it is checked usually 2 to 3 times a day. As far as our individual reps, you can also contact Candace Hunter in West Tennessee directly, LaWanda Mays in Middle, or Laura Lovely Mullins in East Tennessee. In addition to that, my information is on the first slide, and feel free to contact me as well. Once we have your information, we will go ahead and schedule visits with you. We do a face-to-face for the first visit. We will come out with a checklist, and basically the checklist mirrors the program description, and we utilize that to ensure that your practice can meet all of the requirements as outlined by the TennCare program description. Once that is completed, then we will have you sign that checklist, and that will serve as our attestation that you agree to provide the required services. Again, I appreciate your time, and feel free to contact any of us if you have any additional questions or need any additional services. Thank you.
Great. Thank you very much, Philip. Next up, we have Melinda Nelson from United Healthcare. Melinda?
Thank you, Mary. Next slide. So United is continuing to build our MAT network, and I'd like to just highlight briefly how you can become a MAT provider if you aren't already one with our network. If you are currently contracted with United Healthcare, we would amend your existing contract to include MAT services as long as you meet the prescribing requirements and we receive a signed attestation, including your XDEA certification number. If you are not currently a contracted provider with us, you would complete our credentialing process for your specialty and then also satisfy the outlined requirements related to the attestation. As well, new providers to our network would receive a face-to-face environmental site visit prior to contracting. And then finally, if you are a prescriber that does not currently offer counseling services in your practice, you can still participate with the MAT network as long as you have a relationship with a behavioral health counseling provider and are referring your patients out for counseling services. Next slide, please. To bill for MAT services, you would submit a claim as you normally would today. The only difference is that you would use the MAT-specific codes referenced later in this presentation. The case rate billing frequency is an established monthly rate for use with facility care providers. The fee-for-service codes can be used by any care provider and are billable one time per day for the date the service was rendered. Physician-coordinated care oversight and therapy are considered independent services and can be billed on the same day if performed on the same date of service. MAT services don't require prior authorization. We do regularly, however, monitor compliance with the program description and measure that using claims information. And finally, behavioral health physicians, PhD level and master's level behavioral health clinicians can provide and bill for MAT therapy services. Next slide. This is an overview of the codes, the billing codes that should be utilized to bill for MAT services. You'll notice there are specific modifiers that should be included to indicate the appropriate phase of treatment. The case rates would be utilized only by facility care providers, and these codes will be included in the physician or facility contract. And if you are not currently a MAT provider in the United Network and are interested in becoming one, you can call the provider customer service number listed on the first slide of our presentation. There are also resources available at that number for questions for current providers. And then I've also included my number and email for your reference, and I'm happy to field any questions that you might have. Thank you for your time.
Melissa?
Thanks, Mary.
Yes, thank you. Go ahead.
You can move to the next slide, please. So Blue Care began offering BMAT amendments to select in-network waivered prescribers in July of this year, and I'm happy to report that we are meeting our access and availability milestones as of today. So our current focus is on prescribers in target geographic areas to make sure that we meet our January 1 standards, but we have moved to capacity building in some areas of the state. And I'd like to stress that our contracting efforts toward building a high-quality network are very prescriber-focused, especially where there are in-network providers who have amendable contracts. Our amendment documents can basically add BMAT services to just about any Blue Care medical or behavioral core agreement for outpatient services, but we don't extend the amendment documents where there are no waiver prescribers associated with an agreement. We get a lot of inquiries and requests for contracts from entity representatives, typically a business development person or a CEO, and the first questions they will get from us in response is to identify the prescribers who will be delivering the BMAT services under the agreement and where they will be located. Since we have moved to the capacity building phase in some areas, that information is especially important in moving the conversation to the next level, since out-of-network entities that have network-eligible prescribers will be prioritized over those that do not, especially when they are located in an area of higher need. Next slide, please. In terms of billing for BMAT services, the three codes that we've established are fee-for-service and are the same for in-network medical and behavioral specialty prescribers. These codes are filed on a 1500 format, much like you would file evaluation and management codes or E&Ms with add-on codes for typical outpatient services. The Blue Care Provider Administration Manual has additional detail on how to file outpatient claims. And also similar to E&M billing, related labs and pharmacy are separate and billable according to either contract or policy, whatever the case may be. It's very important that you include the HG modifier on the claim with the appropriate HCPCS code, because failure to include the HG modifier could result in a denial or an incorrect payment amount. Any counseling that is delivered in addition to H0033, which is the code that we're using for maintenance without therapy, should be billed according to the rendering practitioner's fee schedule. So, for example, if the prescriber sees the patient today and bills the H0033, but therapy is not delivered until tomorrow by a collaborating LCSW, that LCSW services, let's say a 45-minute individual session, would be billed as a 90834 with a date of service of 12/6/18. Last, it's extremely important that the appropriate taxonomy be used on the claim. That taxonomy is the one that matches what we have on file for credentialing and contracting for the prescriber. This will ensure that your BMAT claims adjudicate against the correct fee schedule. And the last slide, please. With any implementation, there is a chance that you could get inappropriate claim denials or you could hit other snags along the way. And while we look at regular claims reports and try to correct anything that we see proactively or make the outreaches as we need to when things aren't filed correctly, if you run into issues, you can reach out to your regional network manager for assistance. For behavioral health prescribers, your psychiatrists and addictionologists, on the screen you'll see the behavioral health provider network team contact information. If you're a medical specialty prescriber and you don't know who your provider network manager, provider relations consultant is, you can use the My Contact feature on bcbst.com, and that's at the bottom of that page.
All right, great. Thank you very much, Melissa. And thank you to Philip and Melinda as well. This was a great overview. And here are all of the codes that the MCOs are using for your reference. But please remember, you need to be contracted with the MCOs to bill these codes. Next slide. And all the MCOs mentioned a way to contact them individually. Also, if you're not in network, you may also go to the TennCare website, to the opioid page, and complete a provider interest form. We will collect that information and then send it to each of the MCOs. But before the MCO can contract with you, each provider needs to register for a Medicaid ID number. Regardless if you're a new provider to TennCare or Medicaid or an existing TennCare Medicaid provider, you will need to register your information through one of these links below if you've not already done so. And so that includes both individual providers as well as group providers. And you may find this information on the TennCare website. So with that, I'll turn it over to Dr. Wu.
Thanks to everyone and to our MCO partners. They've really been working really hard behind the scenes to help support this. I think we recognize that for many of the MAT providers, this may be your first time contracting with an MCO, and so to that point, all of our MCO in providing their contact information would welcome calls, would be happy to help walk through any of the back office functions that your billers may need to go through, and so the contact information that they provided really are a great place to start. And as Philip mentioned, a lot of the provider reps are on the road in your region on a regular basis, and if you'd like to have an office visit to be able to talk through some of these, they will be happy to support. Of course, you can always contact us at TennCare, and we will happy to help support that connection as well, as Mary mentioned, through the provider interest form if you haven't done so already. But overall, we want to help support the learning process as well from the MCO model that we use here for the TennCare program. Next up, I want to introduce Dr. Ben Heverin, who's one of our medical directors at TennCare, to talk us through some programmatic updates.
Thanks, Victor. Good afternoon, everybody. We at TennCare recognize how important the role of drug screening is in the provision of high-quality medication-assisted treatment. We currently have a limit on drug screenings performed with optical analysis of 12 screens per member per year. Based on feedback, we're excited to announce that January 1st, 2019, we will be increasing this limit, doubling that number up to 24 screens that is allowed per member per year. Next slide, please. To fill in some of the coding specifics here, Codes 80305 and 80306 combined can total up to 24 per member per calendar year. This is the traditional optical observation method of drug screening. Please note that the more advanced screen using instrumental chemistry analysis, such as mass spectrometry, those limits remain at 4 per member per calendar year.
Hi everyone, this is Sarah Mansuri. I'm just going to quickly talk a little bit more about the state and MCO support. So as you've heard throughout this whole webinar, the MAT network provides a ton of resources and supports for providers. So that also means that there's going to be high touch points for our contracted MAT providers. So within the first 2 years of being contracted in the network, there will be in-person check-ins with your MCOs, and this will allow an opportunity for you to ask questions, if that's related to billing or processing, have an opportunity for extra education, and also discuss our quality metrics, which will be on our next slide. We'll also have more virtual education sessions, just like the one we're having right now, as well as assessment of program description to see how well your practice is doing in meeting those requirements. And then after year 3, the touch points will be a little bit less, as we figured you'll be more familiar with the network. And so the touch points will be a little bit less frequent, but you'll still have those in-person opportunities, as well as the virtual education sessions and the quality metric reports. Another benefit that we talked about with the MAT network are the quality metrics. So we're hoping by June you'll receive your first report. So there are 5 domains of quality metrics that we'll be sending out to all contracted MAT providers. These include continuous stage of MAT, relapse rate, concomitant use of benzos or opioid use with buprenorphine, UDS frequency, and behavioral health visits. So these will be on a aggregate level as well as a member level, just to help you assess your population. They are truly for data transparency and education purposes. At this point, they are not linked to any value-based payments. We just want to make sure you have as much information as possible. And eventually, we're hoping for the reports to be distributed quarterly with a 3-month claims run out. And again, we aim for the first report to be sent to providers by June of 2019. I'm going to turn over to Mary.
All right, just a quick slide on Project ECHO. You may have heard an introduction on Project ECHO at the Department of Mental Health and TennCare MAT training back in September. And we are very excited about this collaborative MCO initiative to establish holistic best care model for SUD treatment. So Project ECHO uses a hub and spoke approach to teleeducation. And the hub is the expert team, and the spokes are our MAT providers. And so the training takes place via a Zoom technology, providing easy access to the addiction specialist. And this allows for the MAT providers to present cases and to speak with an addictionologist. So stay tuned for more updates and information about building out Project ECHO in Tennessee.
Great. Lastly, just put a public service announcement out there on behalf of the Tennessee Together legislation and work that's occurring. The Tennessee Together website, tntogether.org, has a lot of resources for providers and patients and community groups around the opioid epidemic. But one of the areas that we thought we wanted to highlight was around the success stories that they're looking to be able to highlight. We all know that in Tennessee there still can remain a stigma for a member or a patient to come forward to seek addiction treatment services or to seek help from mental health issues. And so the success stories is a way that the state is trying to broadcast stories of those members, whether it's related to opioid addiction or not, around those who successfully overcome addiction or would be willing to share their story as a way to help encourage other folks as well. So for all of you who are on the front lines providing care and really impacting and changing lives for the better around the opioid epidemic, we would encourage you to go to the website and consider sharing a story, either if you're a provider in your group or perhaps if there's a member who'd be willing to share their story. We'd love to be able to see that amplified across the state and hopes of supporting other individuals coming forward for addiction recovery treatment services. With that, we'll accept any other questions. Please, again, enter in your name, your organization, and enter in through the chat box, and we'll make sure to answer as many as we can. I'll remind everyone that we will be posting the webinar, a recording, and the slides to the our TennCare Opioid Strategy website. Dr. William Clark mentioned earlier that the PA form is updated and live on the Magellan TennCare website as well. And we really do hope that you will provide continued feedback and support. Contact our MCOs or contact us here at TennCare in order to give us any other suggestions or thoughts as we implement some of these new processes. There's one question asking about the preferred agents. Again, yes, Buprenorphine is currently the preferred agent for contracted MAT providers. They will now have the option of either Buprenorphine as preferred or generic Suboxone, generic buprenorphine naloxone sublingual tablet as also preferred for contracted MAT providers. Second question around how to submit the PAs. Again, you can, if you go back to the PA process, you can support, you can either submit it electronically through Cover My Meds, or you can complete a paper PA form and fax it in. The outcome of the PA will be available to you within 24 hours. However, we encourage you to call the Magellan call center should you have questions or want a faster one. You can also call in the PA form through the same number if you prefer, through the phone, and walk through the process with the Magellan Prior Authorization Center. They will ask you the same questions, and if you're a contracted MAT provider, you will only have to fill out or go through the shorter questionnaire. All right, well, that's the last question that we received. We'll take that as a good sign. We appreciate your time today. Thank you so much for being a part of the fighting the opioid epidemic in Tennessee, and we really do hope and encourage you all to be part of the MAT contracted network. Please feel free to reach out either to the MCOs directly or go to our website, fill out a provider interest form, or refer to these slides for further information. Thanks again, everyone. Have a good afternoon.